hypermobility spectrum disorder, we do see most often tension in the pelvic floor muscles. This can be a variety of reasons. It can be with tissue laxity, so it changes how the force of the muscles are on the joint. We have decreased proprioception. So how we talked about our center of mass is here. If we have less proprioception, a lot of times pelvic floor muscles feel like they need to contract a little bit more to help stabilize. And then also with more mobility in our hips, our SI joint, which sits back here in our spine, the pelvic floor muscles tend to contract a lot more just to trying to provide that stability in the pelvis. We have a lot of ligament attachments also in the pelvis that help stabilize. So again, if we have that extra mobility, the pelvic floor muscles try to kick in and do more. So with having this overactivation, pelvic floor muscles become sore just because they're working all the time and doing more work and not coming back to their tone. One thing I always like talking about, which we kind of already mentioned, when we're up moving around, our pelvic floor muscles are always slightly contracted. So as we mentioned, they close around the urethra and the anus. They lift to kind of give our organs support. When we cough, we sneeze, they give that little extra support and then come back to their regular tone. If our pelvic floor muscles are working harder, instead of just being at this nice level tone, our baseline, they're starting way up here. So now sometimes if we cough, we sneeze, we might not get that support. Sometimes just because of that, we might notice incontinence because those muscles can't support you anymore and kind of let go. And then they just get tired and they get sore just from working so hard. The other thing I always like to bring up is the pelvic floor muscles are also the second most common place we hold stress and anxiety. So just how our upper traps and our neck get really tight from stress and anxiety, pelvic floor muscles do the same thing. For some, this is the #1 place we hold stress and anxiety. Also, any past trauma will also sit in the pelvic floor. Even if trauma didn't occur in the pelvic floor muscles are always kind of our protective mechanism. And so they hold a lot of tension too. So things I always bring up, a lot of times if we go into the doctor and we talk about incontinence, or we talk about issues with bowel movements, or we talk about pelvic pain, we're told just to do Kegels or do pelvic floor contractions, but that isn't the answer. Sometimes that is a need, but a lot of times, how we just talked about, we're actually holding too much tension in our pelvic floor muscles. So if you start doing too many Kegels or start doing too much with your pelvic floor contraction, you actually are just adding more tension and more irritation into this area. So a big focus is just learning how to coordinate our pelvic floor muscles. We want to find out, are our muscles tight and having that extra tone? Are they weak or are they both? So one way I like to practice feeling a pelvic floor coordination is actually sitting on a towel. And I wanted to do that just briefly right now, because then when we go into breathing, we're going to talk a little bit more about feeling the pelvic floor. So if it is handy, I know I didn't warn anybody, but if it's handy, the thing that helps to feel what's happening at your pelvic floor is actually just taking a towel, which I kind of showed a picture. But if you just have like a hand towel and just fold it up and you shape it like a diamond, and then you actually sit on it. So if you have your diamond-shaped pillow or towel, or you could just practice just sitting in the chair where you're at right now. What I want you to think about is your pubic bone, which is the bone in the front of the pelvis, is sitting in the front of the towel. Your tailbone is sitting on the back of the towel. And then we have our two sitting bones, and they sit on either side of the towel. And at any time, Heather, too, if anybody needs a minute, just let me know too. But what we're doing is we're just going to hammock our pelvic floor muscles. And this is just going to give us an idea of where our pelvic floor muscles are. And I just find when we talk about these different strategies we're going to go through, if we have more awareness of our pelvic floor muscles, it just makes it so much easier. So if we're sitting on our towel, right now, our pelvic floor muscles are kind of hammocked in that towel. So I always talk about if you roll your pelvis forward, you kind of feel the front part of your pelvic floor muscles. If you roll your pelvis backwards, you feel your tailbone and the back side of our pelvic floor. And if you shift your hips side to side, you kind of feel like your sitting bones or your butt bones. And that's the 4 spots where we feel our pelvic floor muscles. This is what I have patients do a lot of times when I first see them. And I always say, as we go through this, if you don't feel anything, that's totally fine. We're just starting to get a feel of our pelvic floor muscles. So now if we think about, we have our 4 spots, we're going to place a marble in the center. So if we were to do a pelvic floor contraction, we're going to think that first layer is going to squeeze around the marble. And then our third layer is going to do more of a lift, like you're just lifting the marble off of the chair. And that is a contraction. And if we lift the marble up and then we slowly lower the marble back down and then relax away from the marble, that is a relaxation of the pelvic floor muscles. So what I always say, you can try it a couple of times and just see if you notice one is easier to do than the other, or see if you notice any movement at all. We can also check out if we feel like one side, like we feel a little lift more on our sitting bone, or if we feel more in the front versus the back. And that just gives you an idea of the movement of the pelvic floor. Sometimes if we're holding too much tension in our pelvic floor, it'll feel like we're not really doing a contraction because the pelvic floor is already up. If we feel tension, sometimes it'll feel like we can do the contraction, but when we relax down, it kind of jerks down or it's harder to control. And that just kind of gives us an idea of what's happening at the pelvic floor. But it also just helps our brain recognize where our pelvic floor is too. Cool. Okay. So we're going to keep our towel there if you have one. The next part, how we talked about breathing. So our pelvic floor muscles are considered the second diaphragm. The reason I always bring up breath work is because if our pelvic floor muscle is in a higher tone or staying tighter, it's actually harder to take deeper breaths in because we're not getting that nice movement pattern. Vice versa too, if we're holding tension in our diaphragm, it also makes it harder for our pelvic floor muscles to move as well. So if we're sitting on our towel, I don't know if everybody's done diaphragmatic breathing before, but what we're going to do is if you just put your hand kind of on your abdomen and we just take a nice slow breath in through our nose. So we're just thinking like we're inhaling, our abdomen is gently expanding, and I want you to see if you feel any movement in your pelvic floor. And then what we're going to try is an exhale. So now we're going to do like, I'm not going to blow into the microphone, but do a, and as you exhale, see if you feel any movement in your pelvic floor. The other thing I always like to try too is if you suck in your abdomen. So it's something that we should never do, which we'll talk about. But if you were to suck in or pull your belly button in towards your spine, I want you to feel what happens at your pelvic floor. So when we take a nice breath in, so if we are inhaling, our diaphragm contracts down. So to pull air into our body, I'm going to stand up so it's a little bit easier to see. Here is our diaphragm. So when we inhale, our diaphragm pulls down this way. So it helps pull air into our body. So as our diaphragm pulls air in, our pelvic floor muscles should gently relax down. So diaphragm contracts, pulls air in, pelvic floor muscles relax as we inhale. As we exhale, pelvic floor muscles gently contract, diaphragm comes back up. So it's kind of like our body is a piston where it's just moving up and down. If we're holding tension in our pelvic floor, when we take that breath in, we're not going to feel that relaxation as much. Sometimes it'll feel harder to pull the air in when we're holding tension there too. When we exhale, so if we did that like blowing out, we should feel a little bit of a contraction up. The cool thing with our pelvic floor muscles, even if we're not taking deep breaths, even just our regular breathing in, breathing out, our pelvic floor muscles are always moving. So we talked about how they're still at this nice tone when we're walking around, but they still give this nice movement up and down. So one thing I always like to talk about, even when we talk about relaxing our pelvic floor muscles, they're never fully relaxing where they let go unless we're sitting on the toilet. But even as we're just taking slow breaths and just breathing, they're always moving up and down. I don't know if anybody noticed, if you sucked in or you pulled tension or tightened your abdomens really tight, you actually feel pelvic floor muscles contracting. So that's something to think about throughout the day, because a lot of times walking around, or if we feel like we need that extra stability, or somebody in our past told us to like always tighten your core and pull the belly in and tighten as much as you can, what actually happens is you're just adding more and more tension to your pelvic floor. So you're not really building abdominal muscles, and you're just putting more pressure in we're putting more intra-abdominal pressure, and we're putting more tension in our pelvic floor when we're doing that. So the breath plays a huge part, which we'll get into a little bit later too. So if you have your towel, if you're sitting on your towel, you can take it out. We don't need it anymore. If you didn't, that's something you can always try just to start becoming a little more aware of your pelvic floor, and seeing what happens with breath work, or if you're just contracting or relaxation too. Uh, so one thing we talked about is a lot of times pelvic floor muscles, anytime we have more mobility, they tend to be tighter. I would say almost 90% of people I see in my clinic have tension in their pelvic floor. Sometimes we still need to work on some strengthening, but a lot of times we're just holding tension in our pelvic floor muscles. These are three very simple stretches. I don't know if you even call them stretches. They're more just lengthening and relaxing your pelvic floor. I'm throwing these out there. The one thing I will say is everybody is different. So all of these strategies I'm talking about is more of just like a general base term. Depending on the person and depending on what we notice, everything can change. So if you try any of these stretches and you feel irritation or you feel pain, don't just hang out in that stretch. You want to try something else. So I'm just giving some options, but just be aware that if anything causes irritation, you want to stop. My favorite one, just to start feeling the muscles relax and lengthen, is this modified child's pose on the upper part. So you're starting on your hands and knees. Your knees are coming apart and your feet are coming together. So we're just gently opening the hips. And then I have a foam roller. I have a foam roller sitting on your heels. So that way, when you go into the stretch, you won't go too far excessively. So you're not putting too much mobility in your hips. If you put a little arch in your back, so we're kind of sticking our bottom up towards the ceiling, you're just arching the back enough where you can start feeling your sitting bones separate. So again, if you have a lot of mobility in your spine, you don't need to go to the end range. You're kind of thinking like 70 to 80% of your end range. So you're just going where you start to feel your sitting bones separate. And that is you lengthening the pelvic floor muscles or just like giving them a little bit of a stretch. And once you feel that, you can sit back into your foam roller. So now you're supporting yourself and you can breathe and take those breaths in just to kind of relax the pelvic floor muscles more. So that one's my favorite. The other two are the happy baby, which is on your back when you're pulling your feet in towards you. Again, if you have a lot of mobility in your hips, you want to be aware of not going too far with this one. So what I like to do is actually just put your feet up on a wall with your knees out to the side, like the happy baby position, but that just helps open up your pelvic floor a little bit more. And then the deep squat is another one. Um, we'll get into deep squat a little bit more with toileting too, but a deep squat is a nice way to also open up the pelvic floor. If deep squat is a lot, just sit on a foam roller, or sit on like a yoga block or whatever you have so it lessens the stretch. But like I said, modified child's pose is a really nice one to start with too. But that just helps get our brain connected with our pelvic floor muscles a little bit more. Um, mm, so the four muscles, I think I messed up my slides because we'll go into toileting next, but there are four muscles that help stabilize, that are our big stabilizers of our spine and our pelvis. So we've talked about pelvic floor muscles. We're going to talk a lot about the transverse abdominis. I know there was some questions about diastasis recti, so the separation of our abdomen, and then also just the SI pelvic instability. So we'll talk about that. But I just wanted to bring up our pelvic floor muscles and our diaphragm are the top two, or are two of the stabilizing. So we have the diaphragm on the top, pelvic floor on the bottom. We have the transverse, which is a deeper core muscle, which we'll talk about more. And then we have these little muscles on the spine called the multifidi, which are the other ones. So a lot of times when we are trying to help with stabilization of, like if we're struggling with SI, hip, low back, pelvic stability, a lot of times we need to get the coordination of these four muscles, and then we can start adding like bigger muscles like bridging and squatting and these other exercises. But a lot of times, if we're not getting these muscles coordinated the way we want, it makes it a lot harder for the body to feel that stability in the SI joint and the pelvis too. Um, Things that I also like to talk about is pressure management. So if we talk about, a lot of times we're holding tension in our pelvic floor muscles, we want to try to limit how much pressure we're putting down. One of the things we see often with EDS and hypermobility spectrum disorder is prolapse. Prolapse can be where, which we talk about a little bit later in the slides too, but prolapse is where one of our organs is dropping into the vaginal canal or into the rectum. So we want to talk about strategies that help with our pressure management so we're not putting pressure down. Toileting is going to be a big one, which we'll talk about just with the help with constipation. The other big things I always like talking about is, I always say blow as you go. So anytime you are lifting or anytime you are exerting, you're always exhaling like a. So we felt, well, I don't know if you felt, but when we talked about breathing, when we exhale, we get a little bit of a nice gentle contraction. So we're not getting like this heavy pressure down on the pelvic floor. We're getting this nice lifting up contraction. So we talked about like diaphragm comes up, pelvic floor gently contracts. So if we're lifting, the tendency is always to hold our breath or suck in. And if you remember when you were sucking in, we felt like this increased pressure everywhere. When we hold our breath, we're putting more pressure down on our pelvic floor muscles so that we're putting more pressure down. We want to try to lift the pressure and give our body more of the support. So always thinking when you're lifting a laundry basket, as I am here, anytime you're standing up, if you're picking up a kid, anything like that, we always want to think about exhaling. The other time I always talk about it too is getting in and out of bed. So many times when we roll over in bed or when we stand up, especially after we've been sleeping for a little bit, we tend to hold our breath. So we always want to think about exhaling, blow as you go. Um, Holding our breath also, how we talked about pelvic floor is always doing this nice movement when we are breathing. When we are holding our breath, that just adds more tension. So checking in during the day, always thinking of breathing. If you catch yourself holding your breath, just try to take some nice slow breaths in and out. Okay, so toileting. Toileting is a big part. Um, I'm gonna move, let's see, I'm gonna move my screen because I can't see as well with the pictures, but um, um, so toileting, whoops, did I skip one? Yeah, let me go back. There it is. So toileting. So first for urination, when if we are dealing with any urinary urgency or frequency, when we feel that urge to go, our general census for our body is to rush to the bathroom as fast as we can. A lot of times when we get that urge, and we're rushing, we're teaching our brain and our bladder to rush with us. So sometimes we will notice some incontinence with that urge because our brain and our bladder are telling us, we're going to go, you got to go now, so you better rush. Every time we rush, we just get into that pattern, and that can cause some incontinence. Um, I'm trying to make, I have a lot of information, so I'm trying to make it very simple, but I don't know if anybody's heard of like our parasympathetic versus our sympathetic nervous system or autonomic nervous system. A lot of times, toileting, when we're urinating or having a bowel movement, we want our body to be in a parasympathetic. So, parasympathetic is that relaxed state. Sympathetic is our fight or flight response. So, when we're in a relaxed state, our urination goes better, digestion goes better, we can have an easier bowel movement. When we feel an urge to go to the bathroom and we rush to the bathroom, we're having a heightened sympathetic response. So our body is in that fight or flight response, hurrying up, and it makes it harder for our body to control that urge. So one big thing you can do is just calmly walk to the bathroom. So it's not like we're ignoring our urge, but we want to just calmly walk to the bathroom. So we try to keep our body in that relaxed state. The other thing I always talk about is breathing again. So if we hold our breath, we're adding that tension, which causes our sympathetic system to want to tense up again too. So we always want to think like we're just calmly walking to the bathroom, breathing. What we do on the toilet also makes a big difference. So we had mentioned at the beginning, when we do sit on the toilet, our pelvic floor muscles are meant to naturally relax, and so we can urinate. When we are holding more tension in our pelvic floor muscles, or our pelvic floor muscles are trying to support us all the time, when we sit on the toilet, it's harder for them to relax. So that walking calmly to the bathroom makes a big difference. But also just when you sit on the toilet, breathe and relax. We want to not push urine out, which is also a very common thing, especially if we are rushing to the bathroom or if we're in a hurry or people are waiting for the bathroom or kids are in the bathroom. We tend to rush our urination and we push. Every time we push, we're contracting our muscles and then pushing everything past them. So we want to sit on the toilet and just relax our pelvic floor, even that if that just means just breathing. You can relax your abdomen. So again, if we're holding tension or sucking in, it tenses up the pelvic floor. So we just want to relax them, or relax your abdomen. The other thing that a lot of times people do is they don't keep their feet on the floor. So they tend to come up on their toes or lift their heels up, or they're tensing their leg muscles. And again, all of that tension makes it harder for us to relax on the toilet. So you want to rest your feet on the toilet, or sorry, not on the toilet, on the floor. Rest your feet on the floor and then just breathe. Sometimes you can um, shift your pelvis back and forth. So you can kind of rock your pelvis back and forth if you need to help with urination or just to relax. Or we'll talk about some other strategies too if you notice you can't urinate unless you push. If you stand to urinate, so no matter who you are, sitting is always easier on our pelvic floor to urinate. If you are standing to urinate, you just want to try to keep your hip and pelvis slightly back. A lot of times standing, we shift our pelvis forwards, and that actually tenses up the pelvic floor muscles around the urethra. So you just want to sit back, bring your hips back, and breathe and relax too. So bowel movements. Um, Bowel movements are a huge one. So we see constipation a lot. So one thing which we'll kind of talk about a little bit, but working with another provider for helping with constipation and diet makes a big difference. But constipation puts more pressure and strain on our pelvic floor muscles. Prolapse, if there's chronic constipation, prolapse can also sometimes occur. So we're just trying to make our toileting experience as easy as possible on our pelvis. So with a bowel movement, again, when we feel the urge, we're calmly walking to the bathroom. Now, with a bowel movement, we want to use a stool or a squatty potty. Our body is designed, when we have a bowel movement, our body is designed to be in a deep squat for a bowel movement and for urination. So that's one reason we talked about that deep squat can be really nice. But our society, we don't squat. We sit on a toilet. So what happens is we have this pelvic floor muscle that when we're sitting on our toilet with our feet on the ground, the pelvic floor muscle actually it stays pulled. So there's more of a, let me find my rectum. There's more of an angle at the rectum and the anus. So this comes in handy when we're moving around and doing things so we don't have stool incontinence. But now when we're sitting on the toilet and trying to have a bowel movement, if our pelvic floor muscles are tighter and we have this bigger angle here, we have to strain harder to get the stool, excuse me, to get the stool to come down. So I always say when we're sitting on the toilet, our rectum and anus are kind of at this 90-degree angle. When we put our feet up and we kind of lean forward, so we're getting into the squat position, it relaxes this muscle here so that now our rectum and anus have a straighter shot. So we can have that movement and we don't have to fight against this system that's pulling it. The other big thing we talk about is called belly big, belly hard. So a lot of times when we start sitting on the toilet to have a bowel movement and we're straining, we tend to have our feet on the ground, we pull our belly in, we hold our breath, and we're pushing down. So we're just tensing up our pelvic floor muscles, and it's making it a lot harder to have a bowel movement. So we talk about belly big, belly hard. I always say toddlers, if you ever watch a toddler who's still in diapers have a bowel movement, they always have the perfect positioning. So they kind of go in a corner, they squat down, and then you see their belly get really big as they're trying to push down. So it allows, we're talking about pressure management. You get better pressure, abdominal pressure, and you get the pelvic floor muscles to start relaxing, so it makes it easier. And you can even try it just sitting here now. If we take a nice breath in and we feel our belly kind of expand out, we're thinking like we're making our belly big that way. Now, when you push, we're going to exhale with a push, but we're going to keep our belly hard. So you inhale to bring it, to make it a little bit bigger, and then you push. And you can feel the pelvic floor muscles gently lengthening, and we're getting a little bit better intra-abdominal pressure rather than sucking in and trying to fight against it. I won't lie, if our body is used to like straining and holding tension and holding our breath, the belly big, belly hard is very challenging. But if you keep practicing it, it does get easier. But a big thing is just being able to have a stool, relaxing on the toilet. The other thing I always like to say is our bathroom should be our sanctuary. So we want to try to get our body into that parasympathetic, relaxed state. So having pictures in our bathroom, having plants in our bathroom, having music or anything that makes the bathroom feel more relaxed can also help with our bowel movements too, which is pretty cool. Other big things for bowel movements is actually how we're eating. So we already talked about um, what we're putting into our bodies can make a big difference. Everybody is different. So if you have IBS, even like gastroparesis, like if food moves slowly through your intestines, I always encourage having somebody you can work with, like a dietitian, a naturopath, to kind of figure out what your body needs and what your body agrees with or doesn't agree with. But big things that you can just start with right now is always think about eating slowly and taking small bites, and not having distractions. So if we're eating in front of the TV or if we're eating in front of our phone, we tend to be more distracted. So we're not really listening to what if our body's getting full or how our body is digesting. Our brain is focused more on TV or on our phone and not focused on the digestion part of it. The other thing, we tend to eat faster when we're distracted. So if we take away our TV, take away the phone, it's still great to have talk to someone. So you can still have dinner with someone, but you want to eat slowly, and that helps with the digestive system. We talked about the parasympathetic state already. If we're staying more relaxed while we're eating, while we're having our bowel movements, that will help also. Um, Are bowel movements like routine? So a lot of times just having a more relaxed morning routine, generally speaking, but not everybody, but generally speaking, the first bowel movement typically happens in the morning. So having a morning routine where you can stay relaxed, sometimes having a warm hot pack on your abdomen or drinking a warm drink can just help get the bowels started. Um, there's some gentle stretching you can do with some rotation, which I can definitely go into more. I didn't put it on here just for time's sake. And then there's some bowel movement massage, which we'll talk about too, that can also just help get the bowels moving a little bit. Um, One thing I always bring up with our bowels, normal bowel movements, you can have one every 3 days versus three bowel movements a day. So there's a wide variation of what is a normal bowel movement. The big thing that we are watching for with bowel movements, though, is that you shouldn't feel bloating. And you shouldn't have to strain a lot with a bowel movement. So if you have three bowel movements a day, but you don't feel straining, it feels like you're emptying your bowel movement or you're emptying your bowels, that can be very normal. Same with if you have a bowel movement every 3 days and you don't notice bloating, you don't notice constipation, you feel good, that can be your norm too. But like I said, if we're struggling with straining on the toilet, if we're feeling like we're not emptying our bowels, um, if we're noticing bloating, these can be simple tips you can do. There's also other techniques we do in the clinic to help with the relaxing and movement of our bowels too. There's some different like colon movements we can do. But what I'm giving you today are just the big basics to try. One question that came across was to just children and pelvic floor. What are some of the common things we see? And I brought it in this section because a lot of times constipation is a big thing we see with kiddos. We'll also see bedwetting or urinary incontinence. Uh, 90% of the time with bedwetting, it is linked to constipation. So if we think about how our our rectum and our bladder sit pretty close together in the pelvic bowl. If we are having stool hanging out or we have constipation, that will actually put a little more pressure on the bladder. So we'll get bedwetting at night. Um, The other thing we see is just difficulty with sensory with food. Fiber intake, both for adults and children, is a big thing to help with our bowel movements. And being super careful about how much fiber we should get and being specific about diets, just because that's one thing we know with EDS and hypermobility spectrum disorder is that our what one person can tolerate is very different from another person. Some people can have the great amount of fiber and feel great. Other people have to be more careful with fiber. So I'm not going to get into that too much. Um, but for kids, a lot of times some foods with fiber, they just have difficulty eating because of that sensory. So it does make it more difficult to have a bowel movement. Um, the other big thing, both for kids and adults, is just in case urination. So a lot of times when we're training, we're doing bladder training, or even now as adults, we will go to the bathroom if we're leaving the house or if we're going to go do something. We go to the bathroom and we call it just in case urination. So you don't really have to urinate, but you're going to go just in case. And if you're traveling somewhere, you're going to go just in case you have to go, or if there's something hanging out in your bladder. When we start doing just in case urination, we're actually training our brain and our bladder to go more often. And we can also train our brain and our bladder to give us a signal to go when we're heading out the door. So our brains are amazing. And if it notices every time you leave the house, you go to the bathroom before you leave the house, or if our brain notices every time we get ready, um, to take a shower, or every time we go to bed, we go to the bathroom at the same exact time, our brain is going to remember that and it's going to tell us we have to go even when we don't have to go. Our brain will also tell us if we notice as soon as we walk in our front door, we go to the bathroom right away, even if we don't really have to go. Our brain will start giving us the signal that we need to go to the bathroom as soon as we walk in the front door. So for children, when we start training, which I was trained that way, when we start training to go to the bathroom, just in case, we're starting to develop that process of the brain over the bladder too. So that's one thing I always say. If you are headed somewhere and you know there's going to be a bathroom there, try not to go. If you don't have to go, just wait till you get to your destination. The times are if you're going to go on a long road trip, or for sure before bed, if you haven't gone for a while, go to the bathroom. But we don't want to go to the bathroom just because we're leaving the house and driving somewhere for 10 minutes. And there's a bathroom there. We want to start letting our bladder fill, so it gives us the better signal too. Um, for kiddos with just strategies to help on the toilet. So sometimes we notice, especially with constipation, difficulty having bowel movement. So kids sometimes will get scared to have a bowel movement because it hurt in the past. They don't want to take the time to go sit on the toilet. So we try to do calming strategies, or we try to make it fun on the toilet. So things I do for calming strategies, especially if there was a negative experience on the toilet or they don't want to take the time, and just how we talked about parasympathetic and sympathetic, kids also will get ramped up into their fight or flight mode. So if they've had negative experiences with constipation, they will feel that fear or that fight or flight mode. And so trying to make the toilet be happier and trying to calm the nervous system on the toilet. So I put brushing. So taking one of I always forget the true name, but you know, the brushes that people use to in the shower just to get dead skin off or for rejuvenation. Those brushes are wonderful for calming. So having them brush their leg or brush their arm while they're sitting on the toilet can be very comforting. Um, I do, it's called noodle hard, noodle cooked. So it's another calming mechanism. So Noodle hard is you're in the sympathetic and you're pretending you're an uncooked noodle and you're as hard as you can. And then when you're a noodle cooked, you exhale and you relax. Um, we'll do duck walks to the toilet. So we're
Hi,
getting into
baby.
we're getting into that deeper squat position and we're duck walking to make it fun to the toilet and it kind of helps relax the pelvic floor muscles a little bit more. But those are different strategies we'll do. I'll do uh, blowing bubbles. So practicing like if you're blowing bubbles on the toilet, like a or making it enjoyable that way, that can help relax everything. Um, how we talked about eating and digestion, helping with bowel movement. So when you're eating food, seeing how many bites it takes you or how many chews it takes you to eat your food. So that just helps slow down the eating. Um, and then the other part is using a stool on a toilet, because especially with kids, they're not tall yet. And so if they're sitting on the toilet with their feet hanging, their pelvic floor muscles are having to contract just to help support them. So if you have a nice stool, if you have something they can rest their feet on, that can make a big difference too. This is the I love you massage. Um, it is, I'll go over it briefly and then I just noticed my numbers are kind of harder to see on here, but I'll kind of go over it briefly. But our the stool at the end of our, before it comes towards the rectum, it's going through the colon. So on the right side, it goes up the ascending colon. So this is our right side. It goes up. So here's your ribs. It comes up the ascending colon, across the transverse colon, and then down the descending colon. Um, the places to find, it's you don't have to be super specific when you do it, but if we're starting on the right side, if you feel where your pelvic bone is, you're just coming over from the pelvic bone, you're going up towards the rib cage, across to the other side of the rib cage, and then down to the other pelvic bone. There's multiple different bowel movement massages. The I Love You is the simplest one to do. And it works really well for kids too and babies. But with I Love You, I always talk about we're thinking about if we hear how to brush long hair and you start at the bottom and you work your way up, that's what we're thinking with the bowel movement massage. So we're actually starting at the descending colon. So we're over on the left side. So we're going to clear off the left side first. And we start at 5, which if you can see is on the left side, just underneath the rib cage. And then we're just doing like 3 to 5 circles. So we're always thinking we're going in that clockwise direction. So we're following the pathway that our bowels follow with the colon. So we go 5, come down just midway, 6, 3 to 5 times, and down to 7, 3 to 5 times. And that is our I. Our L, we start over on the right side now. So we're going to do transverse across. So we go 3, 3 to 5 times. Here's 4, 3 to 5 times. 5, 3 to 5 times, and back down. And that's our L. And then the U is just doing the whole pathway, same thing. But that just helps get motility going, and that will help with the bowel movement. So I put it for kids because it's a fun one for parents and kids to do, but this is wonderful for anybody. So when we talked about our bowel movements and they like a morning routine, sometimes after doing like if you've had a warm beverage or if you're relaxed in the morning, 20 minutes after you eat in the morning, you can try this bowel movement massage. The other thing that's nice too is just when you're sitting on the toilet, just move circular directions like clockwise movement along your belly button or around the colon. And just that movement can also, it helps with relaxation, but that also can help with motility a little bit too. Uh, how are we on time? Okay. The other question I got was about diastasis recti. So diastasis recti is the separation of the linea alba um, between the rectus abdominis. So our six-pack muscle that we think about, we have this line in between that connects the two sides of the rectus abdominis, and that's called the linea alba. So diastasis recti is the separation of that linea alba, so it pulls apart. We can see this during pregnancy. Constipation, chronic constipation or straining is another time we'll see diastasis recti. And heavy lifting or carrying will also see diastasis recti. The thing I always like to talk about is a lot of times we're so concerned about how far apart it is, but we actually should be more concerned about how deep it is. So diastasis recti, when we test it, or if you have it and you've been tested for it, somebody will put their fingers by your belly button above and below and have you kind of sit up or lift your head up. And they're checking how wide it is with finger width, but we should also be feeling the depth. So with diastasis recti, when we have that separation, we're losing that stability in the front part of our trunk. So if you remember back at the beginning, we talked about those four stabilizing muscles. And they were we call it a canister. It's the top and the bottom and the front and the back. So with diastasis recti, we're losing some of that good equal pressure everywhere. When we are trying to heal from diastasis recti, a part of it is we need to get our transverse abdominis, which we haven't talked about yet, but we will, which is that stabilizing muscle for our core. That one needs to be engaged more so that even if we have that separation, we still get that transverse from underneath to help give us that support. When we get that underneath and give that support for the diastasis recti, that's going to help with that healing. I don't know if I put it in this one, but one thing I'll show you on this picture because it's easier. One thing that sometimes gets missed is if we're just trying to get transverse activation or we're giving core exercises to start doing to pull everything together. One, if we're not training our transverse properly, we're just using more of our rectus, but a lot of times we're getting our internal and external obliques, which are sitting there, they're more superficial and they're sitting on the outside of the abdominal wall here, and then they come around and attach through here. What we will see is a lot of times with diastasis recti, this internal and external obliques are tighter and holding more tension. So they're kind of pulling it apart even more. So if we try to work on transverse and we're trying to do all the core, instead of getting this nice pulling together, we're getting more pressure pulling apart. So a lot of times what I start working on is we release the internal and external obliques. We relax the rectus abdominis so that we can get better activation of the transverse too. With the transverse, like we talked about, that's one of our stabilizing muscles. So that's going to help provide more of our good pressure system, good pressure management. Transverse is what's going to help also with that, how we talked about the belly big, belly hard, with that defecation for bowel movement. That's going to help with it. There are some different tricks we can do to help with transverse activation. My biggest thing for just starting to feel what's happening is if you put your hand on your belly button, if we take a nice breath out, like that exhale we've been doing, we should feel, or you could do a shushing, like a shh. You should feel this gentle drawing in of the belly button towards the spine. So it's not a sucking in, it's a gentle drawing in, and that's the transverse. Sometimes when we have more of our obliques kicking in, like we talked about, we will notice we'll notice more of like a pushing out, like the belly button pushes out, or we'll also see, you can see where the transverse kicks in here. We'll also feel this rib cage lifting out to the side. That's a sign that your obliques are doing too much. So simple things you can try. Like I said, you can try blowing out your candles. You can try different noises, which I put out here, which I won't spend too much time so we can get through stuff. But you can try different things and you should feel this gentle drawing in of the belly button. If you have diastasis recti and have a little bit of separation, sometimes when you put your finger at your belly button, or if you put it where you have that separation and you blow out your candles, you can feel this little activation there. So then you can kind of feel the transverse engaging. A lot of times um, sometimes when we are taught for transverse abdominis activation, we're told like lie on your back and then flatten your back. So you're trying to tuck your tail, like move your pelvis, flatten your back. But especially with if you have a lot of mobility, if your obliques are kicking in, when you flatten your back, you're using all kinds of other muscles besides the transverse. So when we are starting to try to get this transverse activation, I like using these sounds and just simple activation first. And then, as we talked about, first releasing some of the tension in those other muscles that might be compensating. Uh, the other thing I have found too is sometimes it's hard to do it on your back. Sometimes we just can't get that good transverse activation laying down. So trying it side lying, trying it sitting. I've had some people do it better standing. So we just want to find whatever position we can get into where we can really feel that nice, gentle drawing in of the belly button. We don't want to feel that rib cage flare, and we don't want to feel a sucking in at all too. So we kind of talked about this a little bit with during the transverse. One of the other questions was like if tried other physical therapy for the instability of your SI and pelvis and nothing has been helping. Sometimes it can be we just need to release the muscles that are overtaking and contracting and trying to do all the work. We need to get those to calm down, and then we can start training like the transverse a little bit easier too. Um, a lot of times too, if I am doing some well, if our pelvic floor muscles are having a higher tone and are tighter, this also can limit a good transverse activation because your body is so used to using your pelvic floor muscles instead of the transverse. So a lot of times after we might release the internal and external obliques, like I had mentioned, but also releasing pelvic floor muscle tension, and then we can get better transverse activation. One of the key parts too is if we are releasing like our internal and external obliques, if we're releasing our pelvic floor muscles, we want to, in the same session, also then start activating our transverse. Because if our body is used to always using like pelvic floor to support and stabilize, and it's using our obliques to stabilize, if we get those muscles to relax and then we stand up and try to go on with our day, our body doesn't know what to do. It doesn't know what's stabilizing it anymore. So along the same session, if we're releasing some of this tension, then we want to start working on just simple transverse activation so we can teach our body like, this is what's kicking in, this is what's helping. Um, this is kind of that good coordination we want our body to see. Uh, I did put in here also SI belts, or a lot of times during pregnancy, will be recommended to use an SI belt just as the pelvis starts expanding and preparing for birth. The SI belt just helps support. I also will use it when we're trying to train transverse. If there's a lot of SI instability and we're not getting a good transverse activation, I think it's okay to start using a belt for a brief time so we can start training our body to get that support system. I don't use the SI belt all the time, but it can be a really nice way so you can still be active too. How are we doing? Okay, so other things that we see um, with EDS, HSD, also just general population is endometriosis and adenomyosis. Endometriosis is the one that gets, I think more people have heard of endometriosis. So endometriosis is when the tissue that the endometrial type that's found within the uterus is found elsewhere in the body. So we can see it along the uterus. People have also found it on the bladder, the rectum. There was one case study that found it on the brain. So it can be in different spots. But it does develop scar tissue adhesions. It causes a lot of pelvic pain, abnormal bleeding, bloating, infertility. Um, the way it is diagnosed is usually surgical. You have to go in to see it. A lot of times, MRI or ultrasound won't show it. Um, the latest research I found was 11% they think is in the population. I think it's higher. We'll talk about different things that we can do to help with that. But I just wanted to also compare it with endometriosis to adenomyosis. So instead of the tissue being outside of the uterus and finding everywhere or going to different organs in the body, adenomyosis is that the tissue that lines the uterus grows into the muscle wall of the uterus. Um, so similar, you'll have pelvic pain, abnormal bleeding, like sometimes heavy bleeding, sometimes inconsistent, or bleed for a few days, not have anything bleed again. Infertility sometimes with this one, but it also can cause the uterus to grow or swell. This one can be diagnosed with MRI or ultrasound. Right now, there is the it's reported 20 to 35% of the population, but again, both of these are probably underreported or ignored. Um, I think that was one question about how prevalent endometriosis is. So I think it's more often than reported. Treatment, the first main treatment that usually happens is you get placed on birth control. The only reason I bring this up is it's mm, for I'm gonna for medical standard, that is like the general practice. So stopping menstruation flow so it helps with pain. The hard thing with birth control is it can decrease your libido, it decreases lubrication. Sometimes we notice more urinary urgency frequency. It does change our hormone levels. So this isn't always uh, hmm, this isn't always the best route. For some, it can be really helpful. For others, it is not. I've had some patients tell me their doctor just told them to get pregnant and then they'll be fine. Um, so it's kind of frustrating with what is still being out there or what patients are being told. Um, Conservative treatment that has helped, diet is a big one. Certain foods can be more irritating. Finding what works well for you and what makes your body feel good can help. We do a lot of abdominal releases just because of our fascial tissue, the visceral mobilization, so where our organs are, the fascia tissue, ligamentous attachment, even though we can't change if there is endo or adenomyosis. We can change the pressure that is being put on the uterus or the pressure that's being put on the organ. So doing different abdominal releases, myofascial releases, working on our pelvic floor muscles, releasing hip flexors, different nerve glides. So we have so much happening in our abdominal and pelvic area. We have a lot of nerves in that area, a lot of fascial tension. And just by working on these areas, that can really help with some of the pain and irritation. Uh, when we're in pain or we're having more irritation, we do tend to be, again, in that sympathetic response or that fight or flight response, which then just kind of keeps kicking up our pain and makes everything a little bit harder. So doing different relaxation techniques and calming the body, doing different vagus nerve techniques can help. Again, I'm being very, very general about this because everybody is different. And even with the different releases we'll do or different strategies we do, it's different for everyone. Even if they come in with adenomyosis or come in with endo, our treatment style is going to be based on the person too. But it gives you some ideas of like, if you are working with someone, it gives ideas of things you can try too. Pelvic organ prolapse. So we talked briefly about it at the beginning, but that is something else that we see. So our pelvic organs, we talked about how our pelvic floor muscles do come up and help stabilize. But our organs are also held up with ligaments in our body too, and there's also fascial support. So if we have, with our connective tissue, if we have a little extra mobility, our chances of having a prolapse is a little bit higher. It's not just during pregnancy. It can be with constipation. It can be with lifting. It can be with holding our breath for long periods of time. So, um, a big part is that pressure management, doing the blow as you go, like we talked about, making sure we're not holding our breath, trying to get our constipation under better control. All of that can really help. Um, I can definitely go into more about pelvic organ prolapse and the different types, but I'm just going to keep it kind of simple this way. Um, Other things that help, which I just brought up a few pictures. So pessaries are a tool that is used. Um, this is this is used for prolapse that happens in the vaginal canal. And there's different sizes, different types. So the cool thing with pessaries is that it's fitted to you as a person and your symptoms, instead of just a one size fits all. But the pessaries just are inserted and help support the prolapse. The nice thing with it is you can be more active without feeling the prolapse coming down. Sometimes with prolapse, we'll have incontinence or difficulty with emptying the bladder. And so with the pessary in, that helps give it support. The other thing we have found for pelvic floor muscles, if we support the prolapse, our pelvic floor muscles can function better. So if prolapse is coming down the vaginal canal, our and the rectum, our pelvic floor muscles have something in the middle there, so it makes it harder for them to contract like they should. Sometimes because there's extra pressure there, they stay tight. When we support the prolapse, they can function better. So sometimes with pessaries, people have been found to wear them for a shorter period of time as they're doing pelvic floor therapy and retraining their pelvic floor muscles, and then finding they don't have to use the pessaries as often, which is pretty cool. Um, if we have, it's called a rectocele. So if our rectum is coming down into the vaginal canal, it can make it harder to have a bowel movement. This on the corner is called a FEMZ or a FEMIS, which is the product name, but there's other ones out there. But it is a tool that you can actually just put in the perineum or just in the inside of the vaginal canal to push the rectum back and have an easier time with bowel movement. There's some other little uh, there's what's called the Revive, which is a temporary little support system. It was meant for urinary incontinence, but it also, if you have a little bit of prolapse and unsure about a pessary, it's like a little plastic applicator, but you put it in like a tampon. Um, I'll show you. So it comes like this, and you can just insert it into the vaginal canal, and it kind of helps support. So you can see it's a like temporary thing you can try. If it's just a little bit of incontinence, it just gives you a little support. It kind of closes on the urethra, which is nice. But pessaries are really great. They can be really supportive. It makes you feel like you don't have to worry about incontinence, gives you extra support. And that can be a really nice tool to have too. Uh, Again, so now I'm just going into kind of basics, just giving some broad ideas. Dyspareunia, which is painful intercourse. This also can be painful orgasms. So it's not just with penetrative intercourse. A lot of times with dyspareunia, it can be linked to tension in your pelvic floor muscles. It can be decreased lubrication. So there are different tools out there you can use. There's dilators. So there are vaginal dilators, which help relax your pelvic floor or just get used to gently opening. Again, I'm being super, super broad about this just because uh, I could talk hours about the proper use and when you should use it, when you shouldn't, but I'm just kind of throwing out different ideas, and then it gives you some ideas of questions to ask providers or something to look into. Um, so dilators also are used. There's rectal dilators. So if especially with external genitalia, if you are having pain with orgasm, for anybody, if you have any difficulty with constipation or feeling like you can't empty your bowels, I have a picture of the rectal dilators, and they also help relax pelvic floor. There is a specific way to use them and protocols, which I can definitely send information on. I'm just going real basic about it. Um, Other things that are out there that I always like to bring up is what's called the O-nut, which I think is a lovely, cool design, which I'll show you a picture of. So if you have pain with penetration, um, there are these little plastic silicone um, rings, and there's four of them in a pack, but you can place it on whatever's with what you're using for penetration, so that with penetration, there's a nice barrier. So especially if you're nervous about, if you're feeling better, less pelvic floor tension, but nervous about having penetration, this is kind of a nice little tool that you can start using. Um, they're just one of my favorite products that are out there too. Uh, The other question that was out there asked about mast cell activation syndrome and pain with intercourse and flares after intercourse. So again, I'm being very broad with mast cell because there's a lot with mast cell, but this is just more of that specific question I'm going into. So with mast cell, we do have an increase in histamine levels, kind of like our body just has an over response to something. Um, with so this is with penetration or with if there's semen, that can cause that increase in friction, and then semen that can cause a flare and cause that increase in histamine levels or that increase of mast cell activation. Things I always talk about with this is use a condom. Like we don't want flavored condoms, nothing like that. But using a condom can really make a big difference so the semen doesn't enter, and that can help with flares. Other things are proper lubrication. Uh, if we use a good lubrication, our body produces 50% more lubrication on its own. So lubrication is a huge part. Um, Finding the right lubrication that doesn't irritate you is another part. My favorite is slippery stuff. Most of the time, patients do not have a negative reaction with it, but there are other options for lubrication. The other thing is it also changes depending on your cycle. So depending on where your hormones are, sometimes you can have a bigger reaction than other times. So that's something I always like to bring up, that using a condom, lubrication, and then just being aware certain times of the month can be, you can have more of a flare too. Okay, I'm going to go through the rest kind of fast, but there's information here. I just want to make sure we have plenty of time for questions because I'm going over a ton of stuff. So I might skip through some of this stuff. Pelvic congestion syndrome is another thing that we'll see. Symptoms are dull ache that increases with upright exercise, so walking, running, weightlifting. It tends to increase at the end of the day. Pain will be after intercourse. If the bladder is full, we'll notice increase of that ache, like lower abdominal ache. It does decrease when you're laying down. Little things that can help. So again, this is very general that we're going into, but little things that can help is blood flow does help. So even though we're having increase in pain if we're walking or running, sitting or not moving is not going to be helpful. But strategizing when you can do these different movements. So doing an early morning walk can help. So before the end of the day, if we're having more pain at the end of the day, getting that walk in the morning helps. Swimming is another big one. Swimming is wonderful for this just because it takes the buoyancy takes the pressure off the joints. We get better blood flow. People tend to feel better. Um, Anything you can do to minimize constipation. So constipation tends to also increase symptoms of pelvic congestion syndrome. Um, so finding ways to help with constipation, release of tension in the muscles. Just gonna move this a little too. Releasing tension in the muscles. So we'll do like abdominal releases, hip flexor releases, whatever we find that can help. These are other compression syndromes. One question was about MALS, which is the median arcuate ligament. So where by the diaphragm, it's a ligament on the bottom of the diaphragm. Sometimes it comes down lower, presses on the artery. This causes abdominal pain after eating and exercising. So you'll feel like upper abdominal pain up higher than you would with pelvic congestion. We'll also see nausea, vomiting, diarrhea, bloating. Again, super, super general. It all depends on the person, but a lot of times releasing hip flexors, which are in the front of the pelvis, releasing diaphragm, taking that pressure away can really help. Strengthening, getting better transverse activation, strengthening our glutes, our hamstrings, so the back of the legs can also give you extra support. Posture makes a big difference. If we're arching our back more or we kind of tilt our pelvis more, which is lumbar lordosis, that puts more strain on that area, so you'll increase your symptoms. So working on posture makes a difference. This isn't exactly what I do on the ball, but thinking of like this I'm not quite to this extreme, but stretching out. So we're stretching out our hip flexors up here. We're opening up our diaphragm and our rib cage. And then usually I have the hips sitting out away from the ball a little bit. So now you have to also use your glutes to help stabilize. That can actually be a really nice way to help release some of the pressure. Um, these are other compression syndromes. I might just kind of scroll through these so we'll get past them, but um, similarly too, it depends on the person. We try to release if any area that we're having more tension, we try to release. Working on good posture and positioning also can help take some of that pressure away. Of course, medical attention, getting it checked out is a big thing. Tethered cord was another question that came up. So we're just talking about more with the bladder. With tethered cords, sometimes we'll have difficulty with emptying the bladder. So feeling like we have incomplete emptying. Sometimes we'll have difficulty with feeling the urge when we do have to go. So for either one, whether it's having trouble emptying the bladder or difficulty feeling the urge, the thing we want to avoid is irritating foods. So coffee tends to be a big one. Citrus tends to be another one. Everybody's different, but figuring out which foods can be irritating. Um, these strategies also help anytime anybody's having difficulty with emptying their bladder. So I know I'm categorizing it with tethered cord, but any these strategies can help in a lot of different ways. So if we have difficulty with emptying bladder, again, we want to relax on the toilet. So calmly walking to the bathroom. We try not to push urine out. Things we can do, like if we have with that neurogenic bladder, it just means our bladder's not getting the signals that it needs. So we're just trying to encourage the bladder to empty. So after you go, you try to empty as much as you can. You can do pelvic shifts back and forth on the toilet. So like rocking your hips front to back. You can go side to side. Other things you can try is if you do a very small pelvic floor contraction and just relax, that can help empty the bladder. We talk about small taps on the bladder. So just if you go above your pubic bone, your bladder's hanging out there, you could do little small taps on it. So it encourages it to try to contract, to try to empty the bladder. We don't want to push down on it, but just kind of tapping it. Other things that help is just get up and walk around and then sit back and see if you can relax and urinate. So we're just changing the position where our bladder is. And then there is self-catheterization you can do too if it gets to that point. With feeling difficulty with urge for the bladder, so you might not notice you have to go to the bathroom till your bladder is completely full, which isn't great for our bladder. So setting a schedule. So typically every 2 to 3 hours, if we're having bladder irritants or if you had a ton of water, you just know you're going to have to go a little bit sooner. You just set a timer, set timers so you can start paying attention and getting a good routine going. Other things that sometimes you'll notice if you don't feel the the like urge of the bladder, some people will talk about starting to notice feeling some low back tension or abdominal heaviness, and that can be your body telling you that you need to go too. Bowel movements. So sometimes with tethered cord, we have difficulty with bowel movements. Of course, there's different medications, laxatives, enemas. Um, Talking to your doctor first. So I always say I can give you information to look into, but you'll always want to talk to your doctor first before you start any of these. But we just want to try to get our stool to be the right consistency as much as we can. Um, this goes over just different ways that you can help empty your stool. So there's a like a rectal anal stimulant you can do, which is you're just putting your finger around the rectum and the anus and doing small circular motions for about 20 seconds, and that can help with emptying the bowel movement. Sometimes you have to do finger to do it. We talked about the enemas you can use, which kind of help empty the stool. But again, always talking to your doctor first. And again, this is very general techniques. I usually, it depends on the person and we'll have different techniques for each person too. Okay, just a little past our last 30 minutes. But I thought I would stop there. I kind of rushed at the end just so we could get to questions. And I definitely can go over anything if anybody has questions, because that was a lot of information and there's still tons. I could talk hours about this.
Susanna, go ahead.
Oh, wow, that was quick. Um, it sounds like you do a lot of hands-on stuff, which is awesome. But for those of us who are in the hinterlands of Oregon, do you ever do video consult
I
for people
do.
who can't? Woo.
Yep. Um, since the pandemic, I have gotten very good at virtual videos and figuring out how we can accomplish our goals through video.
Oh, that's terrific. Can I ask another question? There are people waiting.
Go for it.
My Zoom kicked out in a second, and I missed part of the beginning part about activating the transverse abs, but I would love to know. I
Yeah.
got the bit about.
Sorry, I didn't hear the end.
Oh, I got the second half or something.
Oh, okay. So activation of the transverse, we just talked about the simple way is you can do like blowing out candles or a shushing motion. So like a motion. I talked about you can put your hand on your belly button, and what you should feel when you blow out your candles or you shush, you should feel the belly button gently pulling in towards your spine. So we're looking for that gentle pulling in, not a pushing out, not a sucking in. Um, and then our rib cage should gently pull in also. I don't know if you heard this part, but the other big thing with transverse activation is sometimes we have to release like the internal and external obliques on the side of the abdomen, and that makes it a lot easier for transverse to engage too.
Awesome. Thank you.
You're welcome.
iPhone user with your hand up. Go for it.
Yes, I was wondering if you had a recommendation for allergen-free condoms, or I guess especially latex-free condoms.
Ugh. Um, I don't have a brand name. I like that one reason I didn't put a brand name on it is because I have found things I've recommended in the past, patients have not, it has not worked well. Um, Unfortunately, I always say just try, see what helps. I don't know, Heather, if you've heard of any brands that are better.
Does anyone else have any intel on this that they can share? Go ahead and just unmute yourself or pop it in the chat if you like, and I'll say it out loud for you.
There's definitely, because you can always there's definitely non-latex condoms, and like if you look at uh uh what is it? Like just what was the Google I used? Allergy safe, like non-latex condoms. There is quite a few brands that pop up. Um
Okay, that's
I just
great.
can't, yeah, I just can't, I couldn't recommend a specific brand.
Okay, thank you.
Someone put in the chat goat skin condoms.
Yeah, that's another one that I've had some patients not enjoy it. But I've had some patients are fine, like they like it. Mhm.
I had a clarifying question. The bladder toileting slide said to put your feet on the floor, but the bowel toileting slide said to use a stool. So
Yes.
different for the different types of bathrooming.
Yes. So the foot on the stool is more recommended for bowel. Uh when I mean, I always say if you like it on, if you want to urinate with your feet on the stool, go for it, but a lot of times our bladder is put in a slightly different position with our feet on the stool. So I know I talked about like when we squat, squatting is like a great way to urinate and have a bowel movement, but squatting is very different than sitting. So if we're sitting, the stool is better for a bowel movement, and then feet resting on the floor for urination. Um, Sometimes I feel like my answer is always, it depends. So if you're sitting on a really high toilet, a stool would be nice. But if it's a regular size toilet, you can keep your feet on the ground. If you're taller, shorter, that also changes it. But yeah, for urination, you don't need to worry about the stool.
Holly, you
Just
had a
have your
question?
feet relaxed. Mhm.
Hi. I was just curious, do you ever have people with diastasis that's just one-sided? Because with EDS, I had polyhydramnios during my last pregnancy, too much amniotic fluid, and my baby preferred one side. And so that side got really stretched out. And they've done a lot of different scans and things, and they found that the muscles on one side never went back. So it's like I have a one-sided diastasis. And I'm just curious if that's something that can even be addressed.
Yeah, a lot of times So there's different like tactile cueing we can do too. So tactile cueing, like touching the muscle. There's different exercises where we can focus on one side of the body than the other. Again, a lot of the like checking out on the abdominal wall, on the side of your abdomen, on that side that the diastasis recti is. Um, if the other muscles are compensating and holding extra tension, releasing those can help pull everything over. Um, Tactile cueing is like there's one spot where you can feel the transverse on the pelvis, and so cueing that side for better activation. Um, Positioning our legs where the side, well, actually, it depends, but positioning legs where one leg is straighter, the other knee is bent, and seeing if you can get better transverse activation on the side that you have that diastasis recti can be helpful to start retraining it. I'll even use my hands to encourage movement a little bit as we're trying to activate too.
Great, thank you.
You're welcome.
We had one in the chat, which was with hysterectomy in the future, would we want to strengthen before or do more rehab after or both?
Oh, I think it's great before a hysterectomy. So before a hysterectomy, training our pelvic floor muscles. So making sure we can coordinate that contract, that relaxation, getting good transverse activation, getting good even lower body strengthening to help support our pelvis. After we get a hysterectomy, we tend to not be as active right away. Healing time can take a little bit longer. And so going into surgery, feeling better, stronger helps, making like having our body be able to feel that good coordination helps. So then post-surgery, it's important to do, again, rehab to get you back moving again. But a lot of times if we do some good activation prior to hysterectomy, we can have a better muscle activation after hysterectomy too. Plus, there's some cool abdominal stuff we can do post-hysterectomy to help with healing too.
And then the same follow-up question was, is it okay to use weights for part of that rehab? I wasn't sure if they meant pelvic floor weights or like this kind of vaginal weights. Yeah.
Vaginal weights. I am not a huge fan of vaginal weights. If if your pelvic floor muscle is weak and it's more weakness, and you are good at controlling pelvic floor, you can use vaginal weights. There is some research talking about if you do vaginal weight training, you don't have to do like Kegels as often. But sometimes with the weights, using the weights, we tend to then train ourselves to keep our pelvic floor muscles tight all the time, instead of doing this nice contract, relax like we want. So I can't remember the last time I've recommended using vaginal weights. I tend to like to train our pelvic floor muscles and then use our pelvic floor muscles with other strengthening exercises like using body weights. So you're getting that, like, you are working on some endurance with the muscles, but we're not holding tension constantly too, if that helps.
You got to thank you for that.
Cool.
And then another kind of comment, but maybe you could comment on the comment. This one's been in pelvic floor therapy since February. Pain over the ischial tuberosity, which moves into the pelvic floor, is a big thing. Haven't found much to help until we also added in another PT who's working on activating the glutes. I'm that patient that doesn't completely improve. So any ideas about why working on the glutes might have helped with the pelvic floor pain?
Because our glutes sit back here, um, our glutes sometimes become inhibited, or they just don't want to engage like they should. And our glutes, we talked about like pelvic floor helps stabilize. Our glutes do some grunt work. So like when we stand up, when we're walking, when we're lifting, squatting, they are meant to help support our pelvis more. If our glutes are not engaging like we want. When we do simple exercises like standing up, um, walking, our pelvic floor muscles have to work even harder because of the glutes not working like they should. So sometimes we will notice as we do some nice glute strengthening, it helps with this coordination of the pelvic floor. So the pelvic floor, I always say it's like the pelvic floor feels like it doesn't have to work as hard because now the glutes are starting to kick in a little bit more. So that can be one reason. Sometimes just helping with blood flow to the area. When we do a lot of glute strengthening, we're getting better blood flow. We just get better coordination. Yeah, that can be a reason. Sometimes too, depending on your glute strengthening you're doing, we also get a little extra movement with our pudendal nerve, which can be a culprit of pain too. So.
Another comment was just someone had been fitted with the smallest pessary but had trouble with extruding it. So is the option then go to a bigger pessary, wrong shape?
Yeah, that one, yeah, I mean, I would go back to your provider and talk about it. Sometimes it can be the thing we notice is sometimes we'll use a pessary for a little bit of time and then notice it's not the right size. So having your provider take a look while it's in to see what they notice. And yeah, it can be a size or it can be just needing a different type too.
And I've had like two patients with similar situations where they would have an orgasm and have horrible pain in their neck or head. And it was weird because it's like, okay, ergonomics, use a towel. I think they tried all the things and it wasn't going away. So I don't know if you've heard of that or have any ideas about what that could be.
I mean, thoughts about it. A lot of times, so with an orgasm, our pelvic floor muscles do a massive contraction and then relaxation. But um, when we're holding tension in our pelvic floor muscles, and if a patient does repetitive like pelvic floor contraction or a big contraction, during that time, they will start feeling nauseous and will get like headache. And I don't know if it's part of like a vagus nerve response or a like intra-abdominal pressure where we're not getting the oxygen we need, or just the other thought is like this is the top of our canister, our pelvic floor is the bottom of a canister. So if one side has a huge contraction and more pull, the other side is going to do the same too. But yeah, I notice a lot of patients will talk about when they have a higher tone in their pelvic floor muscles and they do Kegels, they will feel nauseous or will start getting a headache too, which is super interesting. Shows our body is just so connected.
Yeah. So I guess, do you do pelvic floor massage
Re
pre-intercourse maybe to help with
yeah,
tone or?
yep, I do relaxation techniques for the pelvic floor. So depending on the person, sometimes that like modified child's pose I showed at the beginning of the presentation, doing that before intercourse to help relax the pelvic floor. I do have some patients who use like a wand, which is another device to help relax the pelvic floor muscles. Some will use a dilator prior to intercourse to help relax and open the pelvic floor. Sometimes just simple breathing of just inhaling and relaxing the pelvic floor. But yeah, for dyspareunia, pain with orgasm, I always say it's hard because it's hard to stop. Like if you're in the mood and ready, it's hard to take a mini break and do these stretches, but it makes such a big difference afterwards.
Any other questions, comments, or people just want to share tips, tricks, etc.? Well, I have one other question I wrote down. I definitely have patients that feel like they can't tell if they're tight or not tight in their pelvic floor.
Hmm.
Like I do external work with people, so I'm trying to coach that without having the ability to touch the muscle for them.
Yeah.
Any tips to help people feel what they're doing? I don't know if anybody else felt that at first during the exercises, I couldn't even feel it and I teach it. So
Yeah. Uh, most often I always say if you can't feel it, most likely you're tight. But um, what I typically do is I'll do if I'm not going to touch pelvic floor at all, that the modified child's pose that I showed or a different opening of the pelvic floor, I will do just to start getting the brain recognizing that breathing and the lengthening. And then I will find once we're more in tuned with the pelvic floor, it's easier to sit and feel that. Um, Sometimes I will teach so again, this all depends on the person because if you have a lot of sensitivity in your pelvis, this isn't wonderful, but I'll teach them like a ball release where you can take like a soft ball or not a soft ball, a squishy ball or like a sock. You can put a sock in another sock to make a little ball. And then you just go by your sitting bone and put it right on the inside of your sitting bone near the rectum on one side and just sit on it and breathe and hold for about a minute. And then switch sides and do the same thing. But that can help. We're just doing like a nice like myofascial release on the muscle. So it just helps relax. And then a lot of times if we go back to the towel, you can actually feel a little bit more movement with it. Because yeah, a lot of times if we're holding tone, like obviously if we're weak, we can't feel that contraction either. But if we're holding a lot of tone, we just can't feel any movement. If we breathe, we can't feel any movement. So trying strategies of like that modified child's pose to relax or ball release, or I'll do an external release sometimes on the pelvic floor if the patient is okay on it, and then have them sit, that can help. Um, Sometimes actually just if somebody is really sensitive with the pelvic floor and the external release or a ball is not an option, abdominal ball releases and just releasing tension in the abdomen and relaxing the abdomen. Then when you go back, it's surprising how much then you can feel in your pelvic floor too. So that's another trick I'll do too. Um, Sometimes I'll get it releasing hip flexors and then have better movement with the pelvic floor too.
we had a chat question about, do you have any information about using like a donut or a disc for sitting?
Mm. I the donut was a very popular thing to use for a long time. If you have severe coccyx pain or tailbone pain, and that's the most comfortable position you can be in, you can use it for short periods of time. I don't like using the donut as much because I find that it restricts blood flow to the area. Um, so I usually try to encourage using a softer cushion that you can tolerate. If you are using a donut, just getting up more often. Just because, yeah, our tissues sink down into the donut, and sometimes that can decrease blood flow. It can also cause nerve irritation too. Um, so I try to encourage to use more of a softer cushion rather than a donut. I just noticed how dark my screen is.
Sun's
It's
going
getting,
down.
I know.
You got a great info for that. That was
Cool.
helpful. What else? Did I miss any questions from the chat? I think I got most things. I think one person had learned the gut massage the opposite direction. So could you just review one more time which
Yeah.
direction you start and which direction you finish?
Always think you're going to the left. So we always want to go to the left or clockwise. I always sometimes get confused with clockwise or counterclockwise. So just think left, always going to the left. So if you're doing, we talked about you could do little circles in different spots. Those little circles, you're always pushing to the left, always moving to the left. So the movement of our balls it's on your right side by your pelvic bone. It comes up the right side to your rib cage, across the bottom of your rib cage, down on the left, if that's helpful.
I like to say too, it's like your clock is facing the world. So
Yeah.
that helps you, like you're showing everyone your clock on your belly and then
Yeah.
trying to go around. Annie.
Hi.
Hi.
Um, so Jen, I have endometriosis, and I am seeing a surgeon in Portland whose specialty in endo excision is neuropelviology. And I was wondering if you had any sort of an emerging field, and I was wondering if you had any experience or training or any thoughts about that particular subject matter. And also, I wanted to say it's interesting having endometriosis and hypermobility. I've had a lot of internal pelvic floor work and worked with pelvic floor therapists, but I haven't had any pelvic floor work for years. And I have experienced a lot of issues with nerve problems in my feet. And recently I went back before I'm having histo and endo surgery in December. Anyway, in prep for that, I started to go back, and it helps my feet, my nerve problems in my feet. So
Yeah.
very exciting. And I mean, I've been to thousands of physical therapy sessions on my feet, and he's telling me that it's coming from the endo on some nerve plexus, and he's going to go in there because he has this specialty, and we'll see what he finds. But anyway, I just wanted to see if you had any thoughts about that. Thank you.
So,
It's been amazing.
yeah.
Thank you.
Oh, thank you. So more like the success rate with that type of surgery, or if it's helpful, is that kind of
My physical therapist, my internal floor physical therapist hadn't heard of the specialty. And I was just curious, if you had
got it.
heard of it, if you had work with any patients that had it, because I know it has other applications as well. Um,
Hmm.
so yeah, it was just kind of a general question and just curious to see.
I do think that's the going way with endometrial surgery. Uh, I haven't had any patients yet who have gone through it. But just with the research coming out, I think we're always trying to find better ways for treating endometriosis. And so this seems to be a more like an exciting route that's happening. And the success is supposed to be better too. But I have not seen any patients yet who have had it done.
Could you just explain how it's different than the traditional approach?
I'm not 100% sure. I need to research it more. I just funny, just read about it or read some research about it the other day. I was looking more for the success rather than the intricacies of it because that's usually what patients ask about too. So I would have to look into it more before I could give the difference.
Chrissy, probably our last question for tonight.
Hi, everyone. I have general pain around where my ovaries would be or where my hips protrude forward, and that's kind of where the all over pain started. We've done a ablation on my uterus, and we've also done explorative surgery for endometriosis and have found nothing as far as any of those things being a problem. The ablation only helped with the initial periods, but not with the pain. I still have it almost all the time. And I also am starting to have pain during intercourse also. Is there anything, as in like that general area, like exercises or stretches or anything that you could recommend? I do also have a lot of lower back problems between the L4 and L5 and L5 and S1. So I've been pretty limited on things that I can do or having to modify things.
Yeah. I can give like general ideas. It's hard to answer it completely without taking a look at everything, but um I mean, because the like our psoas and our iliacus muscles are right in that area also by the pelvic bone too. They can be big culprits of pain and irritation. it's surprising anytime you deal with like ovary pain, um, pelvic pain, pelvic floor muscles tend to hold more tension, and release of pelvic floor muscles can help. There's a nerve that does stem from the like in that area in the spine and wraps around. And doing some gentle like yeah, hip flexor releases can really help with that. Because you have quite a bit of mobility too in your hips and pelvis.
Um, yes, in my hips, the only place I don't have a ton of hypermobility is my knees.
Ah, yeah,
Everywhere else, I'm 100% like it's insane.
yeah. I mean, besides like thinking other thoughts, like I would say, because have you seen somebody to help with like so check out hip flexors, like psoas hip flexors? Um,
Those are definitely things I'll bring up in physical therapy when I see them next
yeah.
week. I also see my doctor in a couple weeks, so I just wasn't sure if there was anything you would recommend I bring up to her because
Hmm.
my appointments with her are pretty spread out right now.
Mm. Yeah, I'm sorry. It's hard for me to say like do this without
Yeah.
like taking a look at everything, but because you're feeling more pressure like in the front of the pelvis here too. Is
Yeah,
that right?
so
On the
where
pelvic
that hip
bone.
bone comes out, closer in towards my belly buttons,
Like
little bit
here.
up. Yes, about right there. Yep,
Yeah.
that spot. Exactly.
Okay. Yeah, so that could be hip flexors. We also have the inguinal ligament that runs right through here. And that can be guarded and tight. Like there's some different stuff we can do on this inguinal ligament. The femoral nerve runs through there too. So especially with your PT, you could ask about like femoral nerve, inguinal ligament, iliacus psoas can also be something to check out for them too.
Okay.
Um, yeah, sometimes we can also have some tension on the like abdominal wall through here too, and that can put a little more pressure in
Yeah,
the
and I
area.
feel it like sometimes it'll pull all the way up, almost like a line up through my abdomen.
Yeah,
So,
that can be, like the obliques we talked about, sometimes that can be a culprit, and there could just be some fascial tissue tension in the abdominal area, especially like um with different surgeries you've had and different things happening in that abdomen, that could
yeah.
also be a culprit.
Okay.
Yeah,
All right.
if
Thank
that
you,
helps.
Adrienne.
Hmm. Yeah. Oh, you're on mute too, Heather.
So silly. We have lots of thank yous in the chat box. People saying what a great job from Emily DeCarlo.
Thanks.
Thank you from
Thanks, Emily.
Claire. We've got thank you from Cecilia. We have lots of thank yous. Great info from Cecilia. Thanks again from Claire. Thank you from Cecilia. Thank you with the big U. That was
Thank you.
excellent from
Thank you.
XXX. And thank you. More thank yous coming. Oh my goodness, Erin, another X. We got Holly. So that was really great, informative talk. We really appreciate that.
Thanks.
Another talk people were saying that they'd love to hear more about would be like parenting and family planning. And I don't know how you feel about that topic, but we would love to have you
Sure.
back. I want to take up all your time, but
Thank you.
that's a whole nother topic that people are always asking
Yeah.
about. Like, what do you do with like the strains of pregnancy or
Uh,
starting family,
yeah.
whether father or mother, and
Yeah, because I did not talk anything about pregnancy, hardly at all. And
right.
like I said, I could talk days about everything. It was hard
Yeah.
to choose what to go over.
Awesome. Well, we'd love to have you back to
Thank you.
cover that topic. Maybe you can throw me out some times that are good for you. We'd
Sure.
love to have you back. So
Thank you.
we usually take off in December for the holidays. It's kind of busy. But we'll probably have a meeting in October and November and January and February. So
Okay.
if any of those are good for you, let us know.
that sounds good. Thank you. Thanks,
All
Heather.
right. Well, thanks everyone for your attention, and look forward to seeing you next time. Let me give you the date here off my calendar. Got to get in the right year first. Let's see. I think we have it for Saturday, October 26th. We'll probably do the 5 o'clock time since it'll be getting dark out a little bit sooner. I think that's the time I've got listed. So we'll put that up in the group for everybody. All right. Well, have a great night. Thanks again. And
Thank you.
I will post the recording onto the YouTube as soon as I can figure out how to do that. I'll get emailed. So if you want it to, Adrienne, you might be having it on your computer as well. I'm not sure. I think somehow we're recording twice.
Okay, cool.
So, but if
Sounds
you want
good.
it, you didn't get it, let me know and I can
Okay.
send it to you.
Thank you.
All right. Thanks. Good night,
All right.
everybody.
Bye.